Okay.
Morning.
Hello, everybody. Thank you all for joining us here today at RGH. Those of you joining us, the two of you joining us in telehealth land, and everyone viewing from WebEx. We got people across the province joining us today, and a few people from out of the province as well. So thank you all for joining us. My name is Jason Vanstone. I'm the research scientist for the Antimicrobial Stewardship program. This is Casey Phillips. He's our lead pharmacist for the program. So today, basically what we're going to give you is a brief overview of some of the data that we've been collecting, both in acute care and with some of the community clinics that we've been working with over the last months and years. So hopefully you'll all enjoy that. We'll have lots of time for questions, I think, at the end and to get to dig into the data. Before we get started, I just want to remind everybody, if you're tuning in from either telehealth or WebEx, if you can either mute your microphone if you're in telehealth land there, and then if you have a question, you can just unmute it. If you're on WebEx, *6 will mute your telephone so we don't get any of that nasty feedback. And we can't hear all of the insults that you're throwing our way out there in WebEx world. So with that, I will let Casey start.
Thank you, Jason. So for those of you who don't know me, my name is Casey, and I'm the lead pharmacist with the Antimicrobial Stewardship program here in Regina. So as just a quick outline, we're going to look at what did we do over the course of this last little while, and from sort of a day-to-day patient care perspective, answering that question that I get a lot as I go around the hospital. So what do you actually do day-to-day, Casey? Well, we'll look at that. And we're going to look at how we measured that as well. So as a general overview, we're going to look at some basic metrics for ASP and the big picture, the big system-wide metrics, but also looking at how do we get down to that patient-level data, the development of our assessment tool that we used, and then we're going to go over our one-year results, and then take a quick look at our tool version 2.0 and how we refined it and what we're hoping to capture with the new data collection tool. So we're missing a picture there, but this is a question I think for a lot of stewardship programs across the province is, you have a stewardship program, and that's going to be different for different locations. In Regina, we're very lucky that we do have physician support. We've got a pharmacist, we've got research support, and data analysis as well, and really strong management support. But in other areas, that program may be limited to just a small group of people having meetings and trying to determine how they move stewardship forward in their area. So when we started, we looked at, do we start in primary care, acute care, and long-term care? Because as we know, stewardship is a problem everywhere. So in focusing down, we're going to look a little bit closer at what we did in primary care and acute care today. So, there are a number of metrics that we use in stewardship, and one really good example, or from the literature, if anyone's looking for just some basics on where to go, what should I collect? There's an excellent article by Andrew Morris, who's kind of like the Canadian rock star of antimicrobial stewardship. And he put this paper together that has some of the basics: DDDs, or defined daily dose, days of therapy, and length of therapy, which are preferable more in pediatric populations, for example. There's also cost of therapy, which is an easily determined metric. And then also working with your micro labs and other resources to just look at your antibiotic-resistant organisms. And you might be looking at prevalence of MRSA, VRE, and some of the newer ones that are coming out, maybe taking a closer look at ESBLs and CREs, and also having an antibiogram. But then, as you get down from that, you can get more into clinical measures, which are really difficult for stewardship programs when you try to attribute what you're doing with the program to changes in mortality or length of stay. That's where it gets a little bit more difficult. So what we wanted to do is we wanted to go from more of that big picture data. Jason, looking at the data, was able to collect sort of a 3-year overview of just what we've been using in each of our hospitals. And we had some good consumption data, but that really didn't tell us much about, well, is it appropriate what we're doing? And, are we going to have any impact here? So we wanted to get down to that day-to-day work that we're doing, the patient level data, to kind of just show, what are we doing on a day-to-day basis for clinical care. And, there's a lot of different, if you're looking for guidance on, what should you do in your stewardship program for audit and feedback activities, or what do you do day to day? There's not a lot of clear guidance on that. I mean, there's big programs like the CDC in the United States. We have Choosing Wisely Canada, which, they're great advocacy groups, and they help support literature and that sort of thing. And they have some good general overviews of what you should have for a program and some of the things that you should be doing. But as far as how to do that, there's no clear recommendations. We also have Accreditation Canada, and as an ROP with Accreditation Canada, hospitals need to have a stewardship program, but it's kind of vague on what exactly those components need to be or what you need to do with your program for the day-to-day work and what that looks like. And finally, we also have, like if you're ID type person or just generally working in the hospital, IDSA is a great resource for looking at evidence-based guidelines, but they even have a great guideline on what you should have as a stewardship program and the different components and breakdowns. But as far as how to put that into practice and make changes, there's no clarity on how that looks. So what we tried to do is we developed a data collection tool using REDCap, which is the Research Electronic Data Capture System. And we have an account for that here in Regina. And over the past year, as the ESP pharmacist, I tried to team up as much as I could with our infectious disease physician who was on call to see different patients throughout the general and Pasqua hospitals. And we developed a data tool that would collect the changes that we're recommending and any sort of monitoring that went along with it. And then I also included in there random ward audits where I could basically, using BDM, create a bit of a sheet where I might target specific antibiotics or a specific ward where I wanted to go see what was happening with the patients. In the data tool itself, we could collect the date, patient ID, and antibiotics. For each antibiotic, we would collect who was the prescriber and what the antibiotic was, and you could go up to 3 antibiotics per patient. Which interventions were done and whether they were accepted or not. So the interventions we looked at was the dose optimized in some way? Was an antibiotic stopped or started? Did we go from IV to PO? Did we narrow the spectrum or did we broaden the spectrum in what we were suggesting? Did we clarify the duration? Was an ID consult generated from what we were looking at or in other consults? Was the treatment reviewed without any changes, or did we order another definitive lab or test, such as if you had a patient with endocarditis or suspected endocarditis, but we didn't have a TEE, making that recommendation to make sure the definitive diagnostics were done. And this is how it kind of came out. REDCap is very similar to anyone who's done something with SurveyMonkey or any tool like that. You just go through and click, and there was very few fields where you had to enter in any information. So it was quite a nice and quick data collection tool. And we collected our data from May of 2017 to just at the end of January here. So it is quite fresh. Just looking at a few of the metrics we were able to pull out. One, just looking at location at the Pasqua Hospital, over that time, we were there roughly 30% of the time and over at the general 70%, and kind of which is a reasonable breakdown considering we have more patients at the general and we're having more ID consults generated here. And on the lower graphs there, you can kind of see, at the hospital, we tried to also get a picture of where we were on the different wards. So our top 2 wards at the general were 3E and 6F, roughly, 20% and 17. And then over at the Pasqua, 3D, which is oncology. So we see a lot of patients there, and 4C are orthopedics. So a lot of directions on, home IV orders and that sort of thing. This is another way to graphically show the data. So on the very top here, you have the Pasco and how many patients we saw over time there, and the general. And then this breaks it down into a month by month look at where we're spending our time. And what we took out of this is that there are specific areas where we tend to see more patients, but we do have a pretty broad overall reach into different areas of the hospital. The next look at what we did, and sorry, it's quite fuzzy on the right side there, but this is looking at each of the prescribers that were included in the audit. So of the 306 patient reviews, we had 99 different prescribers that were identified, and each of them was anonymized by just pairing them up with a number. And we looked at the number of interventions per prescriber, and the results come out on this heat map from a data collection tool called Tableau. And so as areas are darker green or darker red, it shows prescribers that we had more of an intervention with. So it's just a quick look at who we're working with more often. And from there, if we took down just some of that data, we could look at our top 10 prescribers per intervention. So again, those 10 interventions we were looking at. And you can see with the different prescribers that, there's a lot in, for example, the third last column in stop. We have 2 prescribers that we're stopping a lot more of their antibiotics. And some of them, the one in the top right with 19 under no change, that's where we came in to or review the antibiotics. Everything was looking good and we continued, or it might have been a follow-up patient. So for that prescriber, maybe that's a marker of them doing a bit better and we didn't have to change their antibiotics as much, or maybe we're doing more follow-up. It's difficult to say what that information means. And with all of these, there's always caveats, of course. With the patients that we're seeing here, it's largely driven by ID consults. So the patients are more complex, and it might also pull us into more, highly acute areas. Whereas for most infections that we're seeing, they're going to be spread throughout the hospital. And just the last one I'm going to look at here is antimicrobial analysis by intervention. So for each of the antibiotics we were looking at, again, on a heat map, we could see for each of those antibiotics what kind of intervention we were largely doing. So if you focus on the top in the middle there, cefazolin and ceftriaxone, those are ones that we often clarify a duration on. And down on the very, very bottom there, vancomycin 42, that's one that's commonly stopped. We're trying to often start for potential MRSA coverage, and then when we're seeing that it's not needed, we can get rid of it. And again, here, this is actually top 5 antimicrobials by intervention, but again, vancomycin is one that we commonly stop. And there's a few little pieces that I looked at here, but one thing that I thought was good to see as an overall trend, we're going from broad to more narrow spectrum antibiotics in general. And dose modification, one thing that I noticed, we're doing a lot more increasing doses. So as opposed to decreasing doses for something like renal dysfunction, we're often having to increase the dose more to get, more of a dose effect in those deep-seated infections like an osteomyelitis or endocarditis. And one other point here is just with the duration clarification, I think there's a lot of, we get a lot of consults just looking at, okay, this person's been on these antibiotics 2 weeks. Do they need to go much longer? And I think that's a general problem everywhere. But there's a lot of those duration clarifications are also driven by home IV orders and shows a bit of the impact of the ID service on helping get people out of the hospital. So what did we learn from our analysis? Really, there's no set standard for what metrics you should be collecting. And I think for anyone who's trying to develop a bit of a tool to measure what you're doing day to day out there, really try to get it to focus on your specific practice and what outcomes you want to get out of it there. For us, the development of that tool was helpful just in our daily work and in establishing just what we're seeing as a baseline. and provide some ongoing quality improvement as we improve our tool and what we're trying to look for. And it informs us of what our future work might be and potential areas to jump into. But again, a couple of caveats there. As we found, our data tool needed to be updated. And one other thing I found was there's a bit of a learning curve that goes into it, and it takes you some time before you really get comfortable with the data that you're collecting. Another thing is that your data will not be perfect. I think everyone is, there's sort of this instinct to, well, I have to capture everything and be able to show these massive changes. Our thinking was, well, let's start with the basics and what we're doing day to day and build from there. And lastly is just connecting to those clinical outcomes is different. If we look at stewardship and showing interventions that are actually impacting resistance patterns and those more difficult measures, it takes a number of years to really get there. So it's a slow and steady process. And lastly, I just wanted to show you a little bit what we're doing with the tracking tool version 2.0. A couple of things that were missing in there was indication, and I think this is really important, if we're looking for, are these antibiotics appropriate? Just having your antibiotic measure overall is one piece, but if you really want to pare down and get down into your data and say, are we treating community-acquired pneumonia correctly? This allows us to do that a lot more readily. The other problem with our previous tool, it was difficult to track changes. So if a person was changed from one antibiotic to another, it was difficult to find that. So with the new tool, it's going to show clearly you were changed from antibiotic A to antibiotic B. And along with that, we're also trying to track change in the spectrum. So if a person was changed from antibiotic A, let's say it's piperacillin tazobactam, to antibiotic B, cefazolin, we know that it's a change from broader to narrow spectrum, but how broad and how narrow is that? And we found some literature, a study by Madaras Kelly, that looked at a process of assigning a spectrum score to each of the commonly used antibiotics we have in the hospital. So broader antibiotics would have a higher score, narrow antibiotics have a narrower score. And we're going to try to utilize that in the data tool to actually have a numerical value for how we're going from broad to narrow, just as one more measurement to show that overall change in our spectrum score. And from that, I'm going to hand it over to Jason. Thank you, guys.
All right. So, community clinic update. Just as a bit of background, what this is basically, so when we first started, we recognized the importance of an antimicrobial stewardship program having a role in the community, given that's where the majority of the antibiotic prescribing happens. So we, through the RQHR at that time, was running an electronic health record for a group of clinics throughout Regina and sort of the immediate area around us. So we were able to collect information on their prescribing habits and start to go through a process of audit and feedback. We'd provide some information to those physicians and other prescribers, nurse practitioners, for example, in those clinics, and then get some ideas about what kind of information they would like to see, if the information that we were providing was going to be useful for them, would help with changing prescribing practices. And so it's been sort of this year-long process of back and forth as we're trying to narrow down exactly what we want to look at and what to feed back. So what I'm going to present today is basically I've got now 3 years worth of data from 2015 through 2017 for this group of about 12 or so clinics throughout the Regina-Area. So I'm going to present some of that data and some of the initial sort of things that we're drawing from that. For really the sole purpose of beating the proverbial dead horse, I'm just going to go over quickly again. What is antimicrobial stewardship? So again, we're talking about, first and foremost, is an antibiotic necessary? And if it is, great, we want to still use the right drug, dose, duration, and route. So that's really the bottom line, what we're trying to get through to prescribers. And there's all kinds of data that helps us, get to this. So knowing how our use of antimicrobials affects antibiotic resistance. So this, I'm sure most people who have seen this type of presentation before have seen this. So looking at prescribing habits throughout the year. So we can see that in the wintertime, you have a lot in blue here. This is penicillin prescriptions. You have a lot of penicillin prescriptions, and because everyone's sick, going to the doctor, getting their prescriptions. And then the resistance to penicillin here is shown in the orange line. And although there's about a 1 month lag, you see that they peak at the same time. And then as we get into the summer, there's less and less use of antibiotics, and we see less and less resistance in those bugs. And then, of course, in the fall, everyone goes back to school and coughs and sneezes all over each other, and flu season kicks in, and the resistance rates go back up as we use more antibiotics. So we can affect the rate of antibiotic resistance by how much we are using antibiotics. As I said, community engagement for antimicrobial stewardship programs is paramount. This is data that was just released last November from the Canadian Antimicrobial Resistance Surveillance System, so CARS. And so they showed that in 2016, for example, 92% of the antimicrobial doses that were dispensed were done so in the community. So there's a blue bar here. And that is fairly consistent as you go back through time, too. So, as I said, the vast majority of antibiotics are used in the community setting, which is why it's very important for programs to engage with community-based prescribers. Looking more locally, so specifically in Saskatchewan, we are the second highest users of community-prescribed antimicrobials. So that's true in 2016. That was the same in 2013, which was the previous update that they'd had. So not a silver medal that we want to have within our own country. It is, it's something for us to look into and to recognize that we are using a lot of antimicrobials, and to try and get to the bottom of that and how we can change that. So this, I think, is why it's even more important for Saskatchewan-based antimicrobial stewardship programs to engage with those community-based prescribers. We know, for example, that this is not just a problem of physicians prescribing too much or unnecessarily, because there are multiple prescribers, particularly in the community. So, their data here from, again, 2015 showed that family physicians accounted for basically 2/3 of all those prescriptions, but there is, dentists here show a pretty significant proportion, and of course there are nurses and pharmacists involved there as well. So we try to recognize from the stewardship program side of things that we can't just talk to physicians. Yes, they're not off the hook. They do make up a large percentage of those prescriptions, but there are others that we need to engage with as well, and we are working towards that. Trying to get in touch with dentists and see how we can start spreading this word among other prescribers as well. But really the end point here is that of all of those prescriptions in the community, and this is data from the CDC in the US, but they have done a big, long, ongoing study, and their data, this was, I think, in 2015 or 2012, they, at that point, had showed that 30% of their prescriptions, outpatient prescriptions, so either coming from hospital emergency rooms or from those community clinics, at least 30% of those prescriptions are totally unnecessary, i.e. you're prescribing an antibiotic for a viral illness or something like that, which we know an antibiotic is not going to help to resolve. The remaining 70%, while necessary, there's still room for improving the dose duration and the choice of drug as well. And that's their conservative estimate. So that number could actually be as high as 50% of those prescriptions are unnecessary. So 1 in 2. And again, given that community makes up a large chunk of that, that's a lot of prescriptions that we could be preventing just by doing it necessarily. And often what people will say is, well, yeah, that's the US and we might be different in Canada. And just to try and make the point that, no, we're probably not, I just grabbed a couple of recent, just from last year, papers. So Canadian, so this was one that looked at antibiotic prescribing for non-bacterial acute upper respiratory tract infections in elderly persons. This was a study that came out of a group from Ontario. And they found that among those that low-risk elderly cohort, 46% of the patients, so almost half of the patients, were prescribed antibiotics for their non-bacterial acute upper respiratory tract infection. So that shows right there, there's one example of 50% of patients getting an unnecessary antibiotic. This was one that looked across Canada, comparing different areas and regions, at antibiotic prescriptions for outpatient acute rhinosinusitis. So the graph here, it's a little small, but basically the black bars are showing the number of diagnoses of acute rhinosinusitis, and then the gray thing at the top here, the gray line, shows the percentage of people who receive a prescription for that indication. And so that's pretty much stayed steady at about 85%. So 85% of the people who have this acute rhinosinusitis, most often caused by a virus, are receiving prescriptions for antibiotics. So again, I think that just speaks to the fact that we're probably not any different in Canada than what's going on in the United States, at least in the community setting. So what I want to do is I'm just going to flip quickly to another program called Tableau, and I want to go over some of the community data that we've got, and then I'll finish up with, I think, one of the take-home points that I want to come from this. So Tableau, as a disclaimer, is not the only business intelligence software out there. It's just one that we happen to have access to and have used. I find it to be a very useful program for making quick visualizations of your data, and it does allow the end users to actually view data in an interactive way. So as your mouse moves over, I'll show you, you can actually view details about the data, which I think is going to be very useful for providing this information to some of our community prescribers. Just gives you a bit more of a playground, I guess, rather than just looking at an Excel spreadsheet or Excel graphs that have been plopped into a Word file. So I will switch over to here, and let's make this as big as we can. So this is, as I said, that group of about 12 clinics. So they've all been given a code here, G01 through up to, I think it went up to G0 or G10. And I just started sort of chopping through the data. So again, this is 3 years worth of prescribing data. Not all of these clinics have been on that electronic medical record for 3 years. So there are some caveats. There's always caveats to any data that you're looking at, but that's certainly one of them here. And the first part that we're looking here is just trying to compare amongst those clinics the total average number of prescriptions for antimicrobials per 100 visits within that clinic to give us some sort of a denominator. So you see clinics that are higher users of antibiotics on average and those that are lower. And I just threw an average and a median line in here just so people could get an idea of where the spread of the data is. Down here is the monthly number of visits in each clinic. So you can see, for example, Clinic G2 here has quite a high number of visits that they, number of patients that they see in a month. It's number of visits. It could be the same patient coming multiple times, but they do see have a lot of visits there. And then this here is the monthly average prescriptions per 100 visits. So basically, these are the numbers that average out to this number up here. And so you can click around and do things so we can highlight if we want. So if someone was in a prescriber in Clinic G2, they can see their clinic average here, the number of prescriptions, and then they can see their the clinic's average number of prescriptions per 100 visits compared to everybody else. And I like this. It kind of makes for example, this is one story that I pick out when I initially looked at this. I was like, oh my God, these people are definitely going to be throwing out antibiotics like candy. And they're not, which is nice to know. I was pleasantly surprised. So they're right sort of around the middle of everybody else. So that's some cool stuff you can do. And then basically we can pull out each clinic individually. So now we're looking at all of the prescribers within that clinic. And again, their number of monthly visits, monthly average prescriptions per 100 visits. You get some wonky data when people end up having, one visit in a month kind of thing. If we pull out 176 here in August, I think that had one visit. And so if you prescribe that person an antibiotic, then you get 100 prescriptions per 100 visits. So you get wonky data like that, and those are things you just have to sort of work through. But we give them the information so they can sort of figure that out as they go through the data. And then this just goes through all the different clinics, and then we'll get to the really cool stuff down here. So wanting to see, here we go, all prescribers. So now looking at So rather than having to compare themselves just within their clinic, we can look at, okay, how does every prescriber compare to every other prescriber? I'm just going to make this go by number here. So if you are prescriber 100, there is your data. So you have 2.7 prescriptions per 100 visits on average over that 3 years. And that is a total of 479 prescriptions. And of those prescriptions, of the prescriptions that you had, cephalexin made up 54% of the antibiotics that you prescribed. So we can pull out all that kind of data and allow people to see what they're prescribing. And we can sort things by, if we wanted to say who prescribes the most azithromycin, prescriber 160, that makes up 63% of that person's prescriptions. So we can sort of slice and dice and chop through the data in different ways to find out, and if we want to find them over here, where's 160 down here now? So there's 160 down here. Oh, where'd they go? 160. Right there. So they also happen to be the highest user of antibiotics per 100 visits and having 1,015 prescriptions over the 3 years. So giving individual prescribers some information that they can go on and start to really take a deep dive into their prescribing habits and see if they can do anything differently to come more in line with their colleagues potentially. And of course, as I said, this all comes with the caveats of it depends what kind of patients you're dealing with and what things may be ailing them. Wanted to look at, okay, what are our top used antimicrobials amongst this group then? So just did a quick sort: azithromycin, amoxicillin, cephalexin, ciprofloxacin. So over 3 years, 5,000 azithromycin prescriptions, which is a lot, I will say that. Not being a prescriber myself. And so we wanted to break that down. Okay, of those top 4 antimicrobials, who is using them the most? So we've got now the clinics again, G02 through to the end. So for azithromycin here, clinic G02 on average uses 3.9 prescriptions per 100 visits of azithromycin. The highest user of amoxicillin is clinic G01. And then we did the same thing with prescribers. So each prescriber is listed here in terms of how much of each antibiotic they use per number of per 100 visits. And finish the tour with spectrum score. So this is what Casey was speaking about, what we're going to try and do based on some of this stuff that came out a couple of years ago that they've been working on. So trying to give prescribers another way to look at this, since we're lacking indication and we can't really dig down into the appropriateness of what they're being prescribed. Well, let's look at if you're prescribing mostly broad spectrum antibiotics or mostly narrow spectrum antibiotics or somewhere in between. And so that's what we're looking at here. So this is the 3-year average. Each prescriber gets their own dot. And basically what we have is along the bottom is their spectrum score. So the further you are to the right, the more broad spectrum the antibiotics are that you're prescribing on average. And then their average prescriptions per 100 visits is on the left. So the higher you go, the more antibiotics you're prescribing per visit that you have. So to really just broadly put this down, being up here in this corner means you prescribe a lot of antibiotics and they tend to be broad spectrum. Being in the bottom left corner is the opposite. You prescribe fewer antibiotics and they tend to be narrower spectrum when you do. It's not to say that being up here is bad and being down here is good. Again, it depends on the patient population and the types of people that you're seeing. But it does give, for example, a physician who might be able to say, okay, if I'm up here and I prescribe roughly the same number of antibiotics per 100 visits as, say, this physician over here, why am I choosing more broad spectrum antibiotics more often than this physician? And you can compare patients and things like that to try and make some of those decisions. But again, it's just a start for people to do that. And then because this is a 3-year average, I was just playing around with it this morning so we can look at people's prescribing habits over the different years. So I don't know if I'm physician 109, that's my number of prescriptions per 100 visits in 2015, 2016, 2017, and there's my spectrum score for those years. So you can kind of tell, maybe when I first started out in 2015, was I prescribing broad spectrum most of the time, and I've gotten more and more narrow as I've grown in my practice. So just those kinds of things that we can try and pull out of the data. And then we broke it down to a monthly basis as well, which gets a little bit messier, but it just gives you more of that granularity to pick it out month by month. So that's Tableau. I think it's a fantastic tool to use. As I said, it's not the only tool that one can use. But it has allowed us to really sort through. I mean, 3 years of prescribing data from the community is a huge chunk of data to sort through. So it's given us a great start to finding some little indicators of, well, maybe this is something we should pay attention to, or maybe this is a place where there might be an issue that we can work with. One of the things that jumps out for me from this data, and I truly am fairly alarmed here, and I think in my conversations with some of the people in the lab and some of our ID folks, this isn't new. It's been an issue in community for a while, but again, it just jumps out from this data at me. And so you saw azithromycin was our highest used antimicrobial. And so when I had a look at that the data that was sent out through PHAC, so nationally, azithromycin is the second highest used antibiotic at 10%, the highest being amoxicillin. Whereas within this select group of clinics here in Regina, we're basically reversed. So azithromycin being our highest used antibiotic, basically a quarter of the antibiotics that are ordered, and amoxicillin being at 18%. And so the reason that alarms me is because if you're using the antibiogram, which you should be, then you will notice that the group of drugs that azithromycin belongs to, these macrolides, so there's your erythromycin, azithromycin, clarithromycin, all the other things that pharmacists know that I don't, but these are macrolides, I'm told, and they show up on this antibiogram based on our testing for erythromycin resistance. So when you look at that, so this is for our outpatients, this is our RQHR antibiogram from 2016. If you look at just the outpatients, we can see that resistance to that group of drugs ranges anywhere from 21 to 65% resistance. And they're all red or yellow. So probably shouldn't be your first choice of antibiotic to go to, again, depending on what you're treating, but given that it's a quarter of our antibiotics, and likely a lot of those are unnecessary, that's, I think, a place that we really need to start looking for community prescribers and saying, why are we prescribing so much azithromycin, and is it appropriate to be using, especially given our resistance rates locally? I think this is something that speaks to other areas too that have their own antibiograms. You can collect this kind of data either within a hospital, or if you have ability to get community data, and you can look and see what's being prescribed the most, and does that match up with what you're seeing in your antibiogram? Should you be changing those practices, as an example? So where we should be probably holding back a little bit, it seems like prescribers just be letting it rain azithromycin. And so I too, Dr. Malcolm, am fairly alarmed here. So my plea to Regina-Area community-based prescribers is, let's take a look at prescribing habits. Maybe, be careful with how much azithromycin we're using, and definitely use that antibiogram. So it's something that we've been trying to promote with every clinic that we talk to, making sure that there is awareness that you can get it and use it. Question, yes.
Hi, it's Maurice Henning here from Public Health. One of the big reasons for using azithromycin is the STI clinics. Were they included in this group, or were these GP practices?
Yeah, no, these are to my knowledge, not any of the STI clinics that were included. This is just any of the clinics that are on the EMR, the MedAccess EMR.
Okay,
so
because we use Accuro
right.
EMR,
right.
and certainly we, for chlamydia patients and so on, and we see a lot, 1,000 plus.
Yeah, so this is
a year. So they certainly will drive the azithromycin use, because it's part of the pattern. It's appropriate antibiotic as well.
Certainly, yeah. So as I kind of said, one of the caveats here is that we are looking at basically a smaller group of clinics within broader Regina. So whether or not that usage pattern can extend to the broader former RQHR or not is yet to be seen. We're trying to get the data there, but at least within these clinics, even we can say there seems to be a high usage of azithromycin, and the appropriateness piece is yet to be determined. So, because we don't know what these things are being used for, because there is the indication piece isn't there yet. So, yes.
Yeah, so first of all, thank you for the demonstration of Tableau. I've seen that tool, and it was really cool to see it applied locally.
Good.
So that was exciting in a nerdy way. Thank you. I'm a pharmacist here locally, and I'm working on the computerized practitioner order management project for acute care. So this kind of presentation makes me want to explore, and I wonder if this is maybe where you could potentially go, is building in locally clinical decision supports based on local evidence into say the EMR, or like I think Acuro is the most common. Yeah.
Yep, absolutely. Yeah, and that's, I mean, again, if you look at other health systems around the world, that is one of the key pieces of antimicrobial stewardship is if you can build some of these things in, either clinical decision aids or suggestions for antibiotics based on antibiograms, things like that. It's a great way to help change prescribing practice without people even knowing that you're doing it, really, because they just kind of follow along and it just works itself out. So, yeah. Okay, I will open it broadly. If there are questions, let's maybe start out in telehealth and WebEx world. If there are anyone with questions, Casey, come on back up, because if anyone has questions about acute care stuff as well, he's happy to answer. *6 to unmute your phone, or unmute your microphone if you have burning questions. They all look very interested out there. Okay, any other questions then from here, please?
Thank you very much for your presentation. I, too, really enjoyed that tableau. It's a great way to display information. But my question to you is in regards to the community data. Do you have any idea about the age spectrum? Or did you collect that data, whether it was pediatrics, adult, mixed? Can you collect that data? I work on pediatrics, and I know we definitely see azithromycin used inappropriately a lot.
I will have to check back with Caitlin, who collects the data for us, pulls the data for us. We talked about that, and I want to say we decided to go 18 and over, but we didn't collect specific ages we didn't collect patient age with this particular data. But I feel like we did decide on 18 and older, so we excluded pediatric populations from that. Yeah. Yep.
Hi, just Cheyenne here from the General. Just one more quick question for you about that community data. Obviously, it's a little bit easier to obtain indications in the hospital, as some of our projects on different wards have shown. In community, that seems to be a little bit of a limitation for you to be able to really provide more additional kind of feedback to those practitioners. What steps are you guys taking to try to determine indication in community so you can provide more meaningful feedback to the prescribers?
Sure. I guess there is, within MedAccess, so there is a field that they can fill out with the prescription that will allow them to put in the indication. We have certain prescribers who do it 90+% of the time because they know how the workflow works, and then the others do it less than probably 10% of the time for the majority of other prescribers. In talking to some of those clinics, it's not necessarily that there is not an indication at anywhere to be seen in that patient's record. It's just not in that specific cell. And the reason for that is there seems to be a discord between the way the physician workflow goes and the way the workflow is in MedAccess, where they're being asked to put an indication in before, and for writing up the prescription and everything, before they've actually really done their workup of the patient. So one option is to have that become a required field in MedAccess, similar to what we could do with CPOM in acute care, so that before you get to click go on that prescription, they have to fill in what their indication is. That is easier said than done because of the way MedAccess is set up. It's basically, from what I've heard, you can put that idea out to MedAccess, and then they sort of put it to a vote across the country for all MedAccess users. And if everyone decides that's a good idea, that will be their project for the next year. So that's just how they do it. So I think Caitlin has taken that torch and run with it and brought this up to MedAccess, but that's certainly one piece that we can do. Aside from that, it's just really trying to get it out to the prescribers and community that this is an important piece of information we need. And unfortunately, the way it's set up, it has to be in this cell in order for us to collect that information electronically. So,
it's Marina here from LaRange. I have a question.
Sure, Maria, go ahead.
Can you hear me?
Yep.
I'm just wondering if you if there would be any value to linking the physician claims database to your data, and if that you'd be able to obtain indication that way.
Yeah, so that's there's kind of a Bob. Bob's gonna have a go at that one.
Hi, I'm Bob Parker, the program manager for the program. We have had some discussions. Again, there's some logistics around that with regards to data sharing agreements and that kind of thing with the ministry and whoever holds that data. So, but it has come up that this might be one other area that we can incorporate. So we have had those discussions. But again, then it's more how do we filter that information through to aggregate it and clean it and go for that process. But yes, for sure, that is definitely one thing we're looking at.
Make sense?
And yep, totally makes sense. And the other question I have then is, if this data is in MedAccess, it's not necessarily that these drugs were dispensed out to the patient, right? It's just that they were prescribed.
Exactly. Yeah.
Okay.
Yeah.
So to get the full picture, you'd have to link in the drug plan database into that.
Yeah, absolutely. So,
Okay.
so there's the way I kind of look at that is two ways. It's if you have written the prescription, then you intended for that patient to have it. So I kind of use that as the baseline for what would you prescribe first line for an individual physician or prescriber, and then there is that second part of whether or not there's review at the pharmacy level or whatever other level, and whether it actually is prescribed, and that is potentially a slightly different picture.
Okay, thank you very much. Very interesting data.
Thanks. Yes, in the back.
I have a question for Casey. Thanks, Casey. A lot of your, much of your data and your metrics that you presented parallels the inpatient pharmacist metrics that we capture with respect to our interventions with antimicrobials. Did you account for inpatient pharmacist work on those same patients? And was it maybe a reason why your numbers weren't higher, or was it an opportunity that maybe inpatients can learn from your interventions because we're not doing it? I'm just wondering what the parallel was there.
Yeah, no, I think the interventions you'll do for stewardship are going to be the same across the board, right? So that would be the reason why they line up that way. But these were more interventions. This would only be the recommendations that were made by the ID physician and or the pharmacist. So it wouldn't have been, and that was one of those pieces I wanted to make sure we weren't duplicating, tracking the metrics that pharmacists were tracking and we were tracking. So I tried to make sure I was keeping those separate. Does that make sense? Right? Thanks, Rabia. Sort of. All right. Thank you.
Thanks, everyone.